and introduce our next couple of speakers. I'm Dr. Shyam Panchal, by the way. I'll be the moderator for this section. And two of our speakers here right now are Dr. Tanu Garg and Julie Schwartz. We'll be starting with Dr. Garg here, who's going to be talking about prognostication and morbidity and mortality in stroke, and how we kind of navigate that conversation as stroke providers and with our stroke patients and our families.
Thank you, Dr. Panchal. So my topic today is prognosis, intellectual and emotional challenges. So I think our presentation today has gone from acute stroke management to breakthroughs in acute stroke, and also mechanical thrombectomy, and also stroke prognosis and recovery. And I just wanted to take a step back and look at the kind of discussions we have in the ICU or on the stroke floor with our patients and also their family members when they are going through a devastating diagnosis of a stroke or a brain bleed. So the objectives today is I would like to go over the modified ranking scale, which is one of the most common scales we use for disability, and then what is the difference between disability versus mortality, especially from a patient's perspective. And the next would be, are we being too optimistic or pessimistic when we do neuroprognostication for our patients? And then what can we use to prognosticate patients? And last, I would like to discuss a case in which we did use this prognostication pyramid to help answer the family and help guide them in goals of care discussion. So in terms of modified ranking scale, so a lot of the stroke trials, a lot of like stroke recovery trials, we actually use this scale in terms of prognosticating their disability. So, 0 means there's no symptoms at all. 1 means maybe there is a little bit of disability, but the patient is able to do all the activities they were doing before. 2 is there is slight disability and they're not able to carry out all activities, but they're still able to take care of themselves and look after their affairs with minimal assistance. And 3 is moderate disability, which means they're requiring some help, maybe even walking with a walker, but they don't need anyone else to help them walk. And then 4 is where the disability really affects you, where you have moderately severe disability, you're unable to walk without assistance, you need help with your bodily needs. And 5 is severe disability, where you're bedridden, requiring the nursing home care. And 6, as we think of, is a death. And so the difference between disability versus mortality is actually very important, because most of the stroke burden for patients and families actually comes from disability rather than mortality. However, each patient and family that we meet has different values and beliefs, and that does influence the way myself as a physician and what kind of decisions I do make in the ICU and on the floor. Sometimes, especially in cases with large devastating strokes, like large hemispheric strokes, catastrophic hemorrhages, sometimes the decision comes down to intervention with likely MRS 4 to 6 versus no intervention with MRS of 6. And these are very tough decisions that we have to make with the patient and the family, and in a very critical, time-sensitive time. And so neurological outcome prediction or neuroprognostication is a complex undertaking with many important ramifications. So is it more of an art rather than science when we are prognosticating these patients? This is just going back. So how accurate is our prognostication? When we are prognosticating these patients, how accurate are we? So in one of the studies, they actually noted that inappropriately pessimistic prognostic impressions actually claimed the lives of 1 in 4 cardiac arrest survivors. In fact, 1 in 6 might have actually survived to an ambulatory state by hospital discharge. So sometimes maybe we are inappropriately being pessimistic about our prognostication in terms of neuroprognosis. 65% of patients with catastrophic spontaneous intracranial hemorrhage may actually survive hospital death, but the journey ahead of them may be really hard for both the patient and the family, and nearly all survivors die in the subsequent 12 months or be rendered severely disabled. And these are things we have to know, because these are things we do tell the family so they're able to make the decision that's best for the patient. And this is very important because it impacts outcomes, healthcare costs, and also the surrogates and family members of the patients. And so just going back to a case discussion, so I had a 60-year-old gentleman with no reported past medical history who presented with acute onset right-sided weakness, and he was found to have a large middle cerebral artery infarct. So looking right here, all of this is actually damage to the tissue. So he's currently in the ICU, he's obtunded, he's unable to talk at all, he's paralyzed on the right side. And the question is, how do we prognosticate? We did discuss with the family, the patient did not have a living will, but he had some discussions with his family, but no clear consensus was made at that time. And his family involved multiple people, his daughters, his ex-wife, his brothers, and so there were a lot of people involved in his decision making. And so when we look at the pyramid of neuroprognostication, we think of 4 different things. We think of the injury burden, we think of individual values, we think of cerebral reserve, and we also think of cerebral resilience. So I guess the question we all have is that, will your brain actually bounce back? And so talking about that, let's move on and talk about cerebral reserve. So what is cerebral reserve? What I'm trying to ask is, like, how much of the viable tissue is left? Does the brain actually have the capacity to regain a functional state? And these are questions the patient asks us to and the family members ask us. And so in his case, we know that he has actually infarcted a large portion of his brain on the left side. And how much function can he regain from that area is probably not that much. In terms of cerebral resilience, that's actually a very important aspect along with cerebral reserve. So with resilience, what we're trying to say is does the brain have the capacity to dodge an insult? How well did the brain handle insults in the past? So has this patient ever had a stroke before? Has he ever had MI before? How did he bounce back, or what kind of recovery did he have from that stroke? And how much more can he take? How much of the reserve is left, and how much resilience he has left in himself? And these are questions we ask. And based on the story the family had provided, he was a very healthy person. He's never had any kind of strokes in the past, no heart attacks, no big heart or medication problems. So he did have good reserve from the past and maybe some resilience, but he's never had anything where he had to dodge an insult. And then going back to the injury burden, as we said before, that he did have a big injury burden, because a big left-sided hemispheric stroke is a large injury burden. And so going back to our patient, he's obtunded, he's comatose, he's not following commands. And sometimes when we see these patients in the ICU, especially the first and second days, they look like, they're not very responsive. And does that mean that they're truly not responsive? So the topic I did want to discuss today was something called cognitive motor dissociation. What that means is there's basically a disconnection between the activation of the region of the brain to the task that we actually ask them to do. So for instance, if I'm asking a patient, say, show me 2 fingers, and you actually get no response from the patient, my assessment would be like, patient is not following commands. However, they've actually seen with functional MRIs, EEGs, that these patients actually may be following commands because that part of the brain is actually activated. You may not see it, but nearly half of the unresponsive patients actually exhibit signs of brain activation in the acute period. And this is very important because these patients may attain at least partial independence at 1 year mark, whereas only 14% patients who do not exhibit this sign actually achieve milestones. This is one thing also that I tell my residents as well, is that we should not prognosticate too early. We need to give patients some time, because sometimes what we're seeing is not the best exam and maybe it just takes time, and that's what I tell the families as well. And so as I go back to the same thing I mentioned before, so sometimes too early prognostication can also give us a more pessimistic prognostication, as it can be confounded by sedating medications, toxic metabolic derangements. And giving time to the family to process what's going on is also very important. From the first day when you meet the family, the patient, it's important to understand the family values, get to know them, and then understand what the patient would have liked. And so when we rush into prognostication, sometimes we can be overly pessimistic. In terms of the tests available that we can use to guide our prognostications, the ones that we commonly use are MRI, EEG, somatosensory evoked potentials, and sometimes EMGs. There's also a lot of studies about using chemical biomarkers, so doing blood tests where we can look for certain enzymes or molecules like neuron-specific enolase or glial fibrillary acidic protein, neurofilaments, and S100B. But usually right now we use MRIs, EEGs, and in some cases evoked potentials to help us guide if this patient's prognosis would be good or bad. So just going back to the main questions, the question we asked the patient's family was, what kind of routine activities does a patient find most pleasurable? And the family was very confident about this question, because she said the patient is very independent, he lives by himself, he actually doesn't even ask his daughters, anyone for help. And when patients faced with challenging tasks, does he tend to be more motivated or withdrawn? And they were telling me that the patient is the kind of patient where if he's not able to do something, he gets really upset about it. And if he's not able to do things on his own, it's not something that he would like to do. And he gets really frustrated if someone else has to help him with even the smallest thing. And the patient had actually mentioned the family multiple times. He wants to be very independent. He does not want to be living with anyone else. And so what is the first word that comes to mind when describing the patient's attitude towards life? And the family mentioned it was independence. And so based on that, actually the family decided to not pursue aggressive care. They decided not to go for surgery. They actually decided to make him comfort care. And so going back to the modified ranking scale, the family, mentioned that he would never want to be 4, 5, or 6, and even 3 might be too much for him. And that's why they wanted him to see 0, 1, and 2, and that was something that we couldn't promise the family, even if the patient had a life-saving surgery. So yes, the family did decide to take him for comfort care. And so the point that I wanted to make from this presentation was that with stroke, we see a lot of different things. We're making a lot of breakthroughs in stroke rehab, acute stroke management, but sometimes the important part is also talking to the family and understanding the patient's perspective, especially when they're going through that acute stroke. And so being able to talk to the family, being able to understand where they're coming from is very important to help guide your care and also family's care towards stroke management. Thank you.
Thank you, Dr. Garg. So, going into your example here, just very quickly, in your time in practice, have you sort of formulated a time frame for when you decide to have, these conversations, when we talk about making decisions too early versus, being too pessimistic? Have you kind of formulated your own thoughts about when is too early, when is an appropriate time, 1 day, 2 days, 3 days a week? How do you kind of come about that?
I think that's a really good question. And so usually the one thing I know does not work is actually prognosticating the first 24 hours. So when you have a patient who's just went through a catastrophic brain hemorrhage, the family is still trying to process what happened. And so sometimes when we go in there and say, hey, there's nothing we can do, we need to withdraw all care, actually takes the family by surprise, and sometimes they get defensive. So the one thing I've noticed is that the first day what I do is I explain the images to the family. I try to explain to them what's going on and say, this is a lot of information. Why don't you go home, process it, and we'll talk about it tomorrow. Obviously, in cases where the patient is very hemodynamically unstable, they're not able to even make it through the first day. It's a whole different situation. But if the patient is stable enough that they can make it to the next 24, 48 hours, I do like to give the family some time, because whenever we have these discussions too early, I think the families sometimes feel like that the medicine team has given up, that they don't care anymore, and they get very defensive. And also being able to make a bond with your family and the patient is also very important, to be able to make these discussions, especially if you are trying to tell the patient that the best decision for them would be hospice or comfort care.
Thank you.